Recording in progress.
So we'll look for him here in a moment. So he's not with us yet?
Not yet.
I'll text him. Oh, that's fine, just. So on this agenda, we do have Pledge of Allegiance listed, but we're not set up for that here. We do that downstairs on Wednesdays. So at this time, citizen input for any item not on the agenda. Anybody here for citizen input?
I would like to provide input.
Sure, thanks for joining us.
I
You
find
can
it
come to the
really,
table real quick.
I find it really frustrating that we have no way to engage with the commissioners on items on the agenda. We can't do it. Maybe this is different because it's a hearing.
Oh, you have to identify yourself and everything for the
Oh.
record.
Forgive me. For the record, my name is Toby Bayard and I am a resident of the county, just outside Bend city limits. I really find it frustrating. We thought we could come to this meeting and make comments about something on the agenda, specifically the commissioner's efforts to rezone 93 acres of farmland into 9-10 acre MUA 10 zone lots. Similar to what the commissioners voted to do on Lower Bridge. Those lots, well, I guess I can't talk about this, but how do we give you feedback other than voting? And the bulletin.
So, yeah, I mean, this isn't a conversation time, this is citizen input, but let's take a moment. I'm just letting you know, I will today. We're full-time commissioners. We're available at all times to communicate about this. When we have a public hearing on a matter, that's somebody's application that we're responding to, referring to a zone like this. And, you know, public input is put on the record at that point. But you can call any of us at our desk at any time with email. There's lots of communication. We've communicated a lot over the years. So, I mean, when you say, how do you communicate?
Well, I just handed you something.
Yeah.
You
All
can
right,
come on
well-
Wednesday though, because it is a public hearing.
Yeah.
Wednesday.
Wednesday is the public.
Okay,
Yeah,
hearing.
this
I
is
was
preparation for,
Okay, thanks. I think that we.
oh yeah, maybe
And
that's
it's-
clarification. This
it
is
does start at
preparation
this-
for a public hearing. No?
And it does start at 9 AM on Wednesday.
Okay, thank
There
you.
we go. Anyone else? Okay, so item number 1. Commissioner Chang yet?
I texted him to let him know.
That's fine. I mean, and if he's in Salem, he could be talking to a legislator at this time. This is item number 1, preparation for public hearing on the plan amendment zone change. 93 acres.
Hey, welcome. Good afternoon, Commissioners. For the record, Nathaniel Miller, Associate Planner with the Planning Division. The item before us today is a work session to prepare for a public hearing this Wednesday, April 5th. The applicant requests approval of a comprehensive plan map amendment to change the designation of the property from agricultural to rural residential exception area. The applicant also requested approval of a corresponding zone map amendment to change the zoning from exclusive farm use to multiple use agricultural. A little bit about the location and proposal. The subject property is approximately 93 acres in size. It's located just east of Bend, in between Neff Road to the north and Highway 20 to the south. Subject property is comprised of tax lot 1200 and 1201. Both tax lots are under the same ownership. The applicant asked that Deschutes County change the zoning and the plan designation because the subject property does not qualify as agricultural land under Oregon revised statutes or Oregon administrative rule definitions. The applicant maintains that no exception to statewide planning goal 3, agricultural land, is required because the subject property is not actually agricultural land. The applicant submitted a soil study, which was prepared by a certified soil scientist and soil classifier. The study determined that the subject property contains approximately 71% land capability class 7 and 8 non-irrigated soils. According to the study, the subject property is comprised of soils that do not qualify as agricultural land. About the hearings officer recommendation, a public hearing before a hearings officer was held on November 15th, 2022. 3 comments were received prior to the public hearing, one with concerns of the burden of proof meeting the approval criteria. one comment concerned with density. It was a general comment, and one in support of the application. No members of the public provided oral testimony at the public hearing. The hearings officer weighed the evidence and testimony and recommended approval. This recommendation was mailed on December 15th, 2022. No new public comments for the record have been received since the notice of the hearings officer recommendation was mailed. The goal of the work session today is to understand how we can best prepare the board for the hearing and what specific parts of the application the board would like to know more about. Staff would also like to know the board's preference on setting time limits for the applicant and/or members of the public providing testimony.
So Wednesday, I will be at a conference in Hood River. In fact, so Commissioner Dare as vice chair will be running this public hearing.
Aren't you lucky?
Yeah, there you go. So we basically,
Oh, so, I would think, wouldn't we want to do the standard, where we, do we give them 30 minutes to begin with?
Correct, yeah, we typically go applicant 30 minutes, agencies, government bodies 10 minutes, other participants 3 minutes, and then an applicant rebuttal of 10 minutes.
Yes, that seems to make the most sense.
Okay.
I support that, yeah, so there we go. Okay. So this is a hearings officer recommendation, because since it's a plan amendment zone changes, it only happens in front of the board, but it's a recommendation for approval with the points being reviewed at that level.
That is correct.
Commissioner Chang's joined us now. Can you hear us pretty well?
Loud and clear.
Oh, good, okay, here we go.
Congratulations.
Yeah. Any other questions?
Nathaniel, can you review for us past agricultural history or farming history on these properties and water rights? Are there or have there ever been any water rights?
Taking these two apart just a little bit. Yes, so staff is a little bit limited.
So let's talk about procedure here. I know that I've just been kind of warned in the past that this is how we're gonna get to a public hearing. So, and Commissioner Chang, I mean, pardon me, I'm just kind of digesting this. Maybe we want to hear about this at the hearing, or because today's the day to debate.
Yeah. I didn't see, the staff memo was pretty thorough, but I didn't see any information about past agricultural practices or about water rights in the staff memo. So I was just trying to confirm that the information that we had, that is the information that we're going to be using during the public hearing, is complete.
Well, we can ask for that information. I was just pointing out, it jumps right into a hearing if we ask too much about detail.
Sure, I can help clarify. Commissioner Chang, yes, so based upon review of aerial imagery, staff's knowledge, there's been no farming on the subject properties. And there are no water rights on the subject properties as well.
Never? Do you think?
To the best of my knowledge,
Okay.
from my research.
I know it wasn't mentioned in here.
Yeah, I mean, and that was the main point of me asking about this today, is just it's good to know that, and it might be for future applications like this, of which it seems like there are many in the pipeline. It would be good to have that history, even if there is no past farming, no past water rights. It'd be good to just kind of cover that somewhere.
Okay. Yeah, and then the applicant and people listening to this topic will know that's what we're asking for now, so. Sure, yeah.
I kept reading the I and I kept thinking it was you. And then I went, oh, it's Tommy Brooks. So I know, I was thinking like, gosh, to see I this and I that. Anyway,
That's from the hearings officer.
yes, I know. It was just a different feel.
Good, well, and as I say, we had public comment at the beginning of this meeting saying, when do we get to talk about this? Understanding this was the preparation session for the public hearing on Wednesday the 5th.
Yeah. And the applicant's attorney will be providing a short presentation for you at the public hearing.
Any other questions? All set?
Can you,
Maybe.
I would like to know a little bit more about the comments that came in. They were mentioned in the beginning. And you briefly, very briefly kind of told us what they were, but I didn't find like more information about those comments in the staff memo. So if there was a little bit more, like a next layer of information about those comments that were received, I would love to hear it.
Sure. Yeah, I can speak to that specifically. So there haven't been any comments entered into the record, after the public hearing. The comments that were listed here in the staff report represent those comments that were of significant nature pertaining to the application. We did, like I mentioned, receive 2 comments in opposition, 1 comment in support. But other than that, there have been a number of general inquiries as to what the proposal was. As you notice from the maps that I provided in the staff report, it's right up against the urban growth boundary. And so with our mailing radius, there's a lot of folks that were notified just because of the density that's on that East Bend neighborhood. So people were just curious about what was happening, what was being proposed, but there haven't been a lot of comments in opposition to the proposal.
And in the staff memo, there's one that questioned the approvability of the application. What was on what grounds were they questioning the approvability of the application?
So the comment was from Central Oregon Land Watch, and the comment that we received was rather general in nature. It's in the record. It's uploaded to the project webpage, and commissioners can review it at their leisure. But it basically just questioned the approvability of the application.
So maybe sending out the link to the project webpage so we have it in email easily clickable for Wednesday.
I'd be happy to do that.
Chair, there was a handout from the woman who spoke earlier, so what I could do is give it to Brenda for the record, and then she can make sure that Nate has it as well.
Yeah, this one.
Thank you.
I think that was an email too. I think she'd already emailed us today.
Okay.
Or at some time this weekend.
And it might be provided again on Wednesday. Okay, all set.
All right. Thank you, commissioners.
Thank you.
Item number 2, work session at Four Peaks Music Festival. Outdoor mass gathering permit. Is this for 24 or 23?
It is for 2024.
Okay.
Yeah. Do you guys want handouts
I've got them.
or if you got the printouts?
I think we've got.
Okay.
So what happened to 23?
Yeah, so I can address that.
Okay, well, I'm sorry,
Oh, no.
I had it like going, what happened to this? I was asking myself, so.
Yeah, so good afternoon, commissioners. For the record, Rachel Vickers, Associate Planner with the county. For today's work session, we'll be discussing the Four Peaks Outdoor Mass Gathering Permit for their 2024 event. We did hold a work session for this event back in October of 2022. However, shortly after that work session, the applicant contacted me and they wanted to postpone the event until 2024. So they have not, this permit is specific to a June 2024 event, no longer a June 2023 event. So this event will include overnight camping, parking, food, and drink for an estimated 2,000 people. The proposed location is at the same one that it was proposed at in October. 21805 Knott Road in Bend. Setup is scheduled to begin June 15th and tear down to be completed by June 24th. This event will take place from June 20th through June 23rd. This will total a 4-day event, 5 days of setup and 1 day of tear down. The applicant is requesting a waiver from the ambulance being on site, which the board has the ability to grant per DCC 1816-150B. A public hearing for this application is scheduled for this Wednesday, April 5th. Well, DCC 8.16.180 only requires a 10-day notice to other county departments and publishing to the bulletin. Notice of public hearing was sent to those county departments and surrounding property owners on March 17th and published to the Bend Bulletin on March 19th. At this time, staff has not received any comments regarding the proposed application. And at this time, staff is available for questions.
So this will be a public hearing on the matter on Wednesday also. So public hearing on the matter, and then there'll be a completed application. Is that part of Wednesday's packet, or? Is there more? Yeah, there's something in the applicant's paperwork justifying the whole package.
Yeah, so I can include more details in the staff report for Wednesday. There's Deschutes County Code 8.16 requires some certain thresholds, which they're supposed to meet, such as 1 ambulance and 1 first aid station manned by 2 licensed adults and 1 traffic control person per 250 persons. So I can include those base thresholds in my staff presentation.
Okay. Also, just a comment, that there are a couple of years where this event came through the risk management event permit process because they had under 500 people. So that was, I think it was 2 years. But obviously, anytime it's over 500, then it goes through the CDD outdoor mass gathering permit process.
Is there an event this summer that's below 500 or no event?
No,
No event.
they postponed it. Because we originally had talked about it, what was it, October?
Mhm.
I had the paperwork on it, thinking like, well, where's that? And what's happening with it? So-
Yeah.
So were they at 2,000 before? Can I ask you that?
They were at 1,000 people in the October proposal, and since then it has bumped up to 2,000. And outdoor mass gathering can be up to 3,000. So it's between the 500 and 3,000 that is an outdoor mass gathering permit for 10 days. Above that, it goes into extended outdoor mass gathering, and below that, as I understand, is a special event permit.
Question?
Besides the bumping up from 1,000 to 2,000, are there any other changes between this proposal or this application and the one we were looking at in October 2022? In terms of the services that are going to be provided or anything like that?
Yeah, so there are no changes between, the big change was the 2,000 persons. There was a bit more detail provided in the burden of proof that was submitted with this application. However, that was above and beyond the code criteria threshold. So it was more the duties that would all encompass such the crowd control security. So that will include their alcohol monitors, the licensed personnel that will be there, whereas our code requires the 1 crowd control person per 100 persons in attendance. So there was a bit more detail, which I'm sure I can ask the applicant to go into further detail on Wednesday, and I can also include in my presentation.
Thank you.
And these are a little bit different from my experience, where basically the goal is to get to yes. It's instead of slicing and dicing an approval process, basically it's pretty clear criteria, and once you meet it, it's approvable.
Yes.
And, yeah, so they ask for the ambulance is kind of the big.
Yeah, and I'll note that there is a letter of support from Jason Bolin, who works for the Bend Fire Department, in support of the ambulance waiver, which the board has granted in the past. The closest fire station is Bend Fire Station 303, which I believe is about 2 or 3 miles away.
The memo says 2.
I will double check on that.
Okay, so this will be a public hearing on the matter also on Wednesday, Commissioner Derrick.
So are they going to do a presentation then?
I believe, yes, the applicant will be coming up to give a presentation on the matter. Would you like to set a time limit?
Sure.
Okay.
So, I mean, do we do the standard 30 or is this something that's could be done in 20 minutes?
I am not sure. I
20
can,
minutes.
20 minutes?
Probably 20 minutes.
Okay.
Yeah, with flexibility for the applicant.
Right. So we did the 20. It'll be interesting to see if we hear from any of the neighbors.
Yeah, I think I included, or I did not include, in the past, in the 2019 event, there was a few public comments that were submitted, but no one showed up to the hearing. And then for this event, we have not received any public comments yet. Would you like to set a time limit for
Sure.
public comment?
3 minutes.
3 minutes? Okay.
Well, this is June of 24.
Yes.
I mean, who can, yeah, it's over a year away. And then we, what, 5 minutes if they need a rebuttal?
Okay.
Any other questions, Commissioner Chang?
Do we have any history on the size of past events? So I know we were looking at a 1,000 person capacity event for 2023. Now we're looking at these 2,000 person capacity events, but do we know anything about in the pre-COVID days when this event happened, how big it was?
I don't know off the top of my head, but I can include that in Wednesday's presentation if that works.
Wasn't it like at 500? Isn't that what you were just saying?
Yeah,
It was a lot smaller.
the one that came through risk management in 2021, the permit was for up to 500. I don't know what the actual numbers of tickets that were sold. but
Yeah,
that was-
and I'll specifically look at the numbers for previous outdoor mass gathering permits. Or would you like the numbers for special event permits as well?
I'm just curious about this event. Because this festival happened for many years before COVID. And so I understand that in 2021, they only applied for 500, but that was in the middle of the pandemic. So I'm curious about how big it got in kind of peak years in the past.
Yeah, I can definitely look that up and bring that.
Thank you.
Okay, anything else? Seeing nothing else, thank you very
All
much.
right. Sounds good.
See you
guys on
Wednesday.
Now we're way ahead of time.
Well,
I don't know
that's-
how that happens. Sometimes we're like, oh, we gotta fit it in here, and then other times it's good out. But we can do other items for a few moments. I'm sure there's, yeah, I'm sure they're gonna be ready to go there. You think they're all here now?
Yeah,
or
there's
I'm
one
just
more
worried that-
place there.
Okay, well, we can let them know. We're way ahead. I was thinking we could do other items for a moment. but- Welcome. We just powered through the first two items.
Personal
Yes.
Hi. Sorry, Commissioner. Oh, no, I'm sitting.
Well, sorry, are you ready to go or?
We are ready to go. We can either, how do you want to do it, Brenda? Do you want our jump drive with the presentation, or do you want to just go through the slides that you have in your agenda packet?
Or do you want me to try to upload it from the computer?
Get the whole management staff here now.
I made them come
Yeah.
like that.
Yeah, Commissioner Chang's remote. And, it is a recorded published session.
Okay.
We're online. It's extra to have a USB support, right?
I mean, so let me just say, if they have the materials in their agenda packet and available, we don't have to put it
Oh,
on the
it'll be
screen.
up here.
Okay. Whatever's easiest
We
is
got it,
fine.
yeah. It's this, right?
Yeah.
Hold it.
introduce Cheryl's. I'll tell you a funny story about that jump drive. I forgot something. For the,
Okay.
Do you acknowledge?
So, do those doors have to be open then? I don't know, it just seems kind of strange.
It feels strange to me too, pretty
Yeah.
sure, to be
Yeah, I
honest.
know, I was like, going,
I don't like having my back to an open door.
I know, it's not a safe thing to do. In today's world.
Okay.
Say, no, no, I don't want to update, that's what I always.
Too late.
You've got to update. Hi. So I really got to see you again.
There you go.
I just thank you for coming back. It's always nice.
Now we're on to it.
And I was like, get over there, Patty.
Or I'm sorry for this.
Oh. Yeah, okay.
Tell me to format the disk and then I'll find all the data on this.
Did you just find it the parking lot on the way? Well,
Yeah,
we can
did.
get started
We're-
first.
We're not sure what's on
Yeah,
it, but
exactly,
we're about
yeah.
to see.
Well, let's get started.
Let's
We'll
get
going
started.
first
We can at least introduce ourselves. So good afternoon, Commissioners. Janice Garceau, Director of Health Services for the record. I'm going to let my companions introduce themselves just to buy a little time.
Hi, everyone. Holly Harris, Behavioral Health Director. Hello, Jessica Jacks, Program Manager, Prevention and Health Promotion.
Hello, Commissioners. Heather Keisner, new Public Health Director.
Welcome.
Cheryl?
Hi, everyone. Cheryl Smallman, Business Officer for Health Services. And you sent me the invitation.
So Commissioners, we're here today at your request to have a work session related to the proposed use of opioid settlement dollars. And we are coming with some information about the current state and asking for approval of the recommended uses that we generated out of our planning process. So this is why we prepared a PowerPoint, just to give you a little bit of background and base information. And we'll cover some background. We'll talk about proposed strategies. We'll talk about alignment with what we're doing now in the community and the budget picture, and then give you time, if you want it, for questions and answers. The second page in the presentation is a handy dandy acronym sheet. So OD stands for overdose. OUD is a term frequently used for overdose use disorder. That's really referring to folks that have a diagnosis. Opioid use disorder.
Yes.
Yeah. Mental health is mental health, MH. SUD is substance use disorder. BHRN stands for Behavioral Health Resource Network, which is the efforts that were funded through the Measure 110 funds that came to counties to address substance use disorders. DCSC, I think everyone knows very well, PH and BH are Public Health and Behavioral Health. CCBHC refers to Certified Community Behavioral Health Clinics. MAT may be new to you, that's medically assisted treatment. That's the use of buprenorphine, which is a really promising praxis for people with opioid use disorder because it bonds with the receptors for opioids without creating as much of a high. And so it allows people to engage in recovery without the severe cravings and without the impairment in their functioning. Cooper is the Central Oregon Opioid Prevention and Response Entity, and that's an entity that's doing a lot of surveillance and looking at data around opioid use, opioid overdose, and opioid deaths in our community. So for background,
I do have a question already. So this Brunephrine,
buprenorphine.
buprenorphine, does that work on that new horse drug that's out there? Because my veterinarian was explaining to me that she used to be able to give that drug to people to have on hand, and she could no longer do that. So this morning, I was talking to Cheyenne and Megan, and they were saying that there's a real issue with that drug.
So there's a new drug out there that you're referring to, which is a tranquilizer for large animals. And people are now cutting opioids, heroin, and fentanyl with that drug or co-using. That is a phenomenon on the East Coast. We're beginning to see some emerging evidence of it here. I don't know enough about the drug class of that particular drug to have the science down about whether or not buprenorphine is effective. But what I can tell you is that both Narcan or naloxone, which is an opioid overdose recovery drug, and buprenorphine are already challenged by fentanyl. So for example, one of the statistics that we'll cover here is that when we used to administer naloxone to people in an overdose state, it would take 1 point something doses. We'll get to that slide in a minute. And now it takes 3.2.
Right.
And that's really because fentanyl is just so much more powerful of a drug. And getting people to a treatment level of buprenorphine is also proving challenging, because if they're addicted to fentanyl, just getting to a therapeutic dose, they're just coming very close to the threshold of what's no longer a healthy therapeutic dose. So fentanyl has complicated the picture, and I'm sure that this new drug complicates it as well. So the opioid crisis, these are data from 2022, but at that point, since 2000, 500,000 individuals died in the US from opioid-related deaths. The deaths were highest nationally for people ages 24 to 35. Opioid overdose deaths contributed in some part, COVID did as well, but in some part to the decline in the US life expectancy since 2014. And what often is not well accounted for, but is a really profound phenomenon, are the other costs associated with opioid addiction, like costs in the child welfare system, lost wages, long-term health impacts, the criminal justice system, and other health outcomes for people that are struggling with addiction. You can click forward. The litigation one more time, Brenda. States and counties really bore the brunt of much of that crisis. And as a result, states and counties brought claims against the industry, the pharmaceutical industry, representing two things. One, that the industry really misrepresented the risks of long-term use in their marketing campaigns for opioids, and that pharmacies failed to appropriately monitor the distribution of opioids to the public. And as a result, people, regular people getting pain medications became critically addicted to opioids and often descended into pretty severe addiction. Next, the settlement. In 2021, nationwide settlements resolved the opioid litigation that was brought by states and local political divisions. $26 billion was awarded to be distributed in total out of all the litigation. Roughly $26 billion was awarded to be distributed over 18 years. Deschutes County, at our best guess, and again, we're still receiving information about the exact amounts, stands to achieve 6.7 million over 17 years. So one of the things, when we heard the numbers originally, we thought, wow, this is a chunk of resource. And the reality is, other than some upfront resource, it's not a lot of money over a 17-year period. The first couple of years, it definitely yields some opportunity, but after that, it's dwindling fairly rapidly. Next slide. What does it look like in Central Oregon? Between 2018 and 2021, the rate of overdose deaths in Central Oregon increased by 85%. And preliminary data, which again is just preliminary data, this is not fully vetted data yet, shows that we're on track to have roughly 100% increase in overdose deaths. Now, these are overdose deaths that may involve polysubstances, opioids, methamphetamine, which is still accounting for quite a few overdose deaths as well. So this is not necessarily an opioid specific statistic. Next slide.
Don't you find it fascinating though that we were down to 14 deaths in 18 and 19? And
They've doubled.
yeah, it's doubled, and I kept asking for this number, you keep seeing it. And then I went through and pulled up all the mortalities starting from 2005, where Oregon was at, and we were at a much better spot.
Yeah, the whole country was at a better spot.
No, but we were way at
Yeah.
a better spot. Our deaths in 2005, and then from 6 to 13, this National Center for Statistics wasn't even available. But we
Yeah.
were at 10.4 per 100,000 in the
Yeah.
state of Oregon.
Yeah.
Pretty decent.
Yeah. Yeah, I mean, the opioid epidemic, the prescribing crisis, and then the COVID, definitely, we saw huge impacts to people with substance use disorders, the isolation, the loss of employment, the loss of connection to recovery activities that people were engaged in definitely took a toll. So next slide, Brenda, sorry. Oh, Cheryl, sorry. Click. These are animated slides, apologies. So there were, just in Central Oregon, there were 273 visits to the ED for opioid overdose in 2022. Of those, 185 were Deschutes County residents.
Which
And
is
of-
2/3.
which is roughly 2/3. And of those, 44 involved fentanyl, which is lower incidentally than the statewide average. The statewide average is about 64% of overdose deaths are related to fentanyl. Next one. This I talked about before, about what we're finding is that the doses of naloxone required for rescue increased from 1.7 to 3.2 doses over the last 4 years. Next. The graph on the right shows the distribution of ages. So nationally, it's 24 to 39, I think. Say 24 to 35. And we're somewhat consistent with that, but we have higher rates in the 20 to 29 age group than what the national statistics represent for the population of people struggling with overdose. Next. So one of the things to be aware of is that this data really represents the tip of the iceberg. What we know is about 68% of Deschutes County individuals who reported using naloxone for rescue to our harm reduction staff did not contact an ED. So when we're looking at statistics that are collected community-wide, and most of those are being generated by EDs or emergency responders. And we know that that only represents about 1/3 of the population of people that may have experienced overdose. We know the number is much higher. If we were to just take a guess, that would be about 850 overdoses a year, or roughly 2.4 a day. It's a guess, but the problem is much larger than what is represented statistically. Some of the things we're doing currently, and you can skip through. Pain Standards Task Force is a group of folks that have been meeting since, do you know? Probably 5 or 6 years.
Yeah, I was gonna say just before the first regional health assessment.
So maybe 7 or 8 years. And their task was really focused on this overprescribing phenomenon, and there was concerted effort made to help physicians understand the impact of overprescribing, help people access better ways to manage pain and to monitor pain medications more closely. And that graph shows you the decline in problematic prescribing practices in Deschutes County. This is the graph for Deschutes County compared to the state. We're keeping right in step with the state. And that's a very promising graph. It really means that those prevention efforts have been very successful and problematic prescribing has decreased significantly.
How do they determine problem prescribing? Like, what's the criteria or definition?
I don't know. I think it's, I don't know. I mean, I know that there's a whole sort of strategy around training people on how to talk with folks in the hospital and the ED about pain medications, not prescribing extended doses, so often prescribing in week-long increments, giving people more coaching about the dangers of pain medication, how to titrate off pain medication, offering them, I mean, I think about when my partner went to the hospital with a severe injury, the conversations they had with him about creating a tracking sheet for when he was dosing himself, interspersing the doses with ibuprofen. So practices like that, I think, are part of how physicians have been trained, and maybe the two of you know more about that than I do.
I don't recall the specific prescription that they were looking for to, but essentially they came up with there was a standard, hence pain standards task force that we were locally looking for, and we were seeing people meet that.
So somebody must have gone through and looked back at what the prescriptions were and then made a determination.
Yeah, that's a really good question, though. It makes me curious too. Like, how do you get to be a dot on that graph that's lower than the one before? So we can look into that and get more.
Well, I remember in the 90s, someone I know had an orthopedic issue and they were given 40 Oxycontin pills.
Yeah, can you
Probably
imagine? You can die from that.
And they probably needed 4.
Yeah.
You know, so it's definitely an issue. Was it Dr. Sullivan? Who was the pain doctor that was so outstanding? Part of that program. Do you remember, Jessica, what her name was?
Dr. Kim Swanson?
Oh, Swanson, yes, right.
Yeah.
Okay, yeah, she, you know, what an asset to that group. So
Yeah.
is she still practicing?
She's in private practice.
Okay.
Harm reduction is another project that's been really successful. There has been 98 naloxone rescue events reported in 2022, which is double what we reported in 2021. So that program is one of the programs that was expanded through the Behavioral Health Resource Network funds that came to us in October. And then next item, and then the Deschutes Stabilization Center sees a significant number of people actively intoxicated on any number of substances. 40.2% of the encounters that we, you know, the services that we record in our medical record represent people that have co-occurring mental health and substance use disorder diagnoses. 21.9% of encounters had active intoxication upon arrival. So what that means is 1 in 5 people that we serve are intoxicated, or drunk, or they are under the influence of an opioid or methamphetamine, or all of the above.
Do we have an individual chart then on, are they on alcoholic drugs?
Do.
Do we know?
We do break
What
it down. We
breakdowns?
we break it down between alcohol, methamphetamine, THC, polysubstance use, opioids, cocaine, psychedelics, benzos, opiates, kratom, and inhalants. And I mean, again, though, this is, I think those numbers, those are the ones we know for sure. There's lots that we're sort of like not entirely sure what's going on. We can't say one way or the other if it's you know, so there's probably a chunk of people missing out of this data, but those are still pretty significant numbers of the ones we know for sure.
Yeah.
That either self-reported or we had some evidence that they were under the influence.
So we're going to shift into proposed strategies. Are there any other questions about the data?
One thing to note on the stabilization center data, we did just start collecting it since July of last year. That was not collected since opening. So I just wanted to point that out.
So we thought a lot about how much resources actually available, what's realistic that we can do. I think we're sensitive to conversations around adding FTE. So we really thought about what can we do to build on what we're already doing with the resources available and enhance and better coordinate our efforts. Oops. Oh. So we're proposing a multi-strategy approach that keeps disappearing. to enhance our coordination and response efforts. So we're proposing investments to expand capacity of existing efforts by adding targeted expert, you can go ahead and click, targeted expert opioid use disorder prevention. Some FTE committed to increasing our coordination of surveillance efforts, both internally and with external partners. And then third, maintaining and sustaining existing interventions such as harm reduction, the stabilization center, and other kinds of prevention activities that we're engaged in. So in terms of targeted, and we aligned all of the strategies to the allowable uses and the Exhibit E of the opioid settlement document. So targeted expert prevention, the goals of this particular strategy would be to improve awareness and utilization of effective opioid and other drug prevention knowledge and skills in order to prevent and reduce adolescent drug use, and specifically focused on opioid use disorder in particular. The cost, this is an existing FTE, so this is not a new FTE. This is an existing position that right now we have not filled because we do not necessarily have resources identified for it. It came about as part of a reorganization of our prevention services. It's a community health specialist 3. The cost of it is $135,396 a year. And we would assign $20,000 roughly a year for educational, marketing, public service announcement kinds of materials and contracts. Next slide.
Janice, I just had a conversation this morning with Jessica Pratt from
Yeah.
AOC.
Yeah.
And she said that for what she is seeing just recently, 90% of the youth have no idea. So education clearly needs to go to them. Remember last year we lost a young man
We
from
did.
Summit.
Yeah.
And she said that was what she was incredibly surprised about. So
Yeah.
I'm going like, with this going on, why don't we have some billboards or something going up immediately to get in parents and kids' faces?
Yeah, and we have, like, internally, we've circulated and we've sent out to the people that we know of information about, for example, when there were some disguised fentanyl pills floating around. But what we really want to do is do that in a more thoughtful, coordinated, strategic, broad way. So this is part of the kind of work that this role and the role that we'll talk about in a moment would be involved in, along with some of our existing positions in our harm reduction program. And I'll talk about how all these things connect. When we
Okay,
get a
well,
little
I mean, I'm
further
just
in.
thinking, we've
Yeah.
doubled our overdose and we have an emergency. It's been scaring me to death for a long time.
Yeah.
You know, I know somebody who finally, you know, they overdosed and died.
Yeah.
But according to what I looked up, Idaho, I thought, well, what are other states' bias? Idaho has had a 12% increase in deaths. And compared to Oregon, that's really nothing, what our deaths have been. But that's in 22. And they're really worried about, you know, what's going on there. And they're saying, well, they don't have treatment facilities, you know, in smaller towns.
Yeah.
So, you know, I'm just thinking, I love everything to be planned, but I do believe we have an emergency and at least putting it out there as quickly as we can.
Yep.
Before we get this person hired, you know, how many months can that be? That we find a billboard and we start like, parents, you've got to know this is happening in our community.
I think that's something we can think about right now.
Okay, well, it just was like, oh my gosh.
So the activities that this particular position would be engaged in are very targeted, expert, specific to opioid use disorder, and then other substances as well. Prevention activities connected to schools and at-risk youth. So they would review, recommend, and support community implementation of effective opioid and other drug prevention programs, including training as appropriate in churches, youth-serving organizations, and schools.
So what happened to the person that we did have in the schools? Jessica, isn't there somebody still there?
Yeah, we have a prevention person in the schools, but they have to focus on all substances and do not necessarily, first of all, we don't receive funding for opioid specific prevention intervention. And they may not necessarily have the level of expertise that I think we would hope for, given the nature of the crisis. And you can say more about, I'm speaking for you.
Just riding your coattails.
Yeah.
Are you, Commissioner, referencing the person that we had in Sisters in La Pine?
Yes, we did have somebody in both of us share those two schools.
Yeah, we, so the funding for that work has shifted 3 times and not allowed us to maintain that focus. So it's nuanced, so we don't have that position in schools anymore. The only positions we do have in schools are the Healthy Schools Public Health Specialists,
Which isn't only in Ben Lapine.
which is only in Ben Lapine. It doesn't mean we don't have a presence in Sisters and Redmond. It's just a different type of presence and not as in depth and I would say not as efficient as we could be.
And this
So
is
when do
sort of
they
general
leave
broad
the
substance
schools?
prevention.
Jessica, when did they leave the schools in? I mean, was it in the middle of COVID?
Yes.
So these are some of the activities. They would also coordinate age-appropriate opioid and other drug prevention education and awareness to parents and families across the spectrum of 5 to, I think it says 24. My slides were cut off and I can't see them on the screen either. Develop and distribute communications for sustained community awareness. So things like we were talking about emergence of disguised fentanyl or upticks in certain kinds of drugs that are circulating. Next bullet. And support data collection and provide regular summaries of data. For this particular project, the outcomes would be to develop and deliver a minimum of 10 opioid and other drug prevention workshops for parents by June 30th, 2024. To conduct outreach and provide opioid and other drug prevention technical assistance and training to a minimum of 10 organizations that serve high-risk youth by June 30, 2024. And that's really specific to kids that are not necessarily in school. Those are kids that may be in shelter, that may be unhoused, that may be in alternative settings. And develop and provide opioid and other drug prevention awareness and education through multiple communication strategies that reach a minimum of 500 families by June 30, 2024. So that is the targeted prevention strategy. The next sorry. Any questions? The next strategy is to improve our surveillance and our coordination of that surveillance with our existing efforts. These dollars would be applied to 0.2 of an existing supervisor role. The goal would be to improve coordination with internal and external entities working to reduce opioid overdose deaths and opioid use harms, and ensure real-time surveillance systems to quickly respond to overdose emergencies. So the statewide surveillance system is often giving us data a year after the fact, if not more. And that's helpful data for a look back. It's not helpful data for a community response. So we're working really closely with some local entities that are looking at real-time data, what's going on in our community now, what are the drugs that are circulating now, where is the highest risk, who's encountering that risk, and trying to coordinate our strategies when we're doing outreach into the community to be aligned with the people that are most at risk. This role would help coordinate that effort. The cost is there, it's 0.2 of the position. It is an existing FTE.
I thought you were saying 20 cents.
No, I wish.
No, I mean, I was looking at this guy, $28,280.20.
Oh, 0.2 FTE, yeah.
Yeah, I know, but anyway,
Next,
a little more space.
next slide. So the activities of this particular role would be focused on infrastructure and staffing for collaborative cross-system coordination, to prevent opioid misuse, prevent overdoses, and treat those with opioid use disorder and any co-occurring substance use and mental health conditions, or implement other strategies to abate the epidemic as described in the opioid abatement strategy. It would also monitor surveillance, data collection, and evaluation of programs described in the exhibit. It would provide it would coordinate with epidemiological surveillance of opioid use disorder related behaviors in critical populations, including individuals entering the criminal justice system and including, but not limited to approaches modeled on arrestee drug abuse monitoring system. And coordinate with statewide, regional, local, or community regional planning to identify root causes of addiction and overdose, goals for reducing harms related to the opioid epidemic in areas and populations with the greatest needs for treatment. We identified one measurable outcome for this particular role, but it's fairly broad. It's to develop an internal coordination plan for responding to overdose health alerts in real time in Deschutes County by December 31st, 2023. Any questions before I move on?
Yeah, Janice,
Yeah.
when you say cross-system, I mean, does that mean a whole lot of agencies outside of the county family, or is that
Yes.
within county?
It's within and outside. So we have things that we're doing in behavioral health that are focused on this population, things that we're doing in public health that are focused on this population. We coordinate with our regional public health and behavioral health partners. And then, and I'll let you talk about who else we're coordinating.
Yes, so part of the kind of regional coordination that has been happening is this system called ODMAP. I don't know if you've heard of it, but it's the Overdose Mapping Application Program, and it's really a real-time system to collect data, working with our EMS partners as well as our police officer partners, sheriff's office, to really try to understand in real time when we're seeing spikes in overdoses and being able to really target the area, so we can do really, really targeted messaging to a specific area, whether it's a geographical area, demographic area, and then also our hospital system, which is what is our surveillance system that we already have, that we work with St. Charles on. So like, during heat, during fire, we can look and see what's coming in through the ED, what are we seeing as far as chief complaint, things like that. And so we can also do that with overdoses as well. So it's coordinating with a lot of different local partners.
Thank
I don't know if you can see me.
I don't think you can see you, but he can hear you. Other questions about surveillance and coordination?
So I don't know if you guys saw the numbers from Portland this last weekend. Didn't they have like 3 overdose deaths and then 13 calls or something? I mean, and it was, horrific. So what would Deschutes County do? Let's say we, with your strategy here, what would we do if that happened here? Let's say we had one, like every week we had 1 death. Right now it's every other week is how it looks. What would we do differently? How are we going to impact and change the what's going on?
So Jackson County has done some of this work, and we're really looking to them as well. And so you have different levels of like, okay, here's when we see this level of spike, we go into, you have like red, yellow, green. Green is kind of what we're kind of our baseline. And that's what we need to determine, as a system. And then yellow is, okay, we're seeing an uptick. And that's when we start looking at, we get all of these groups together really quickly, and we could put out fast media releases, we could put out health alerts, whether that's to a broad, all tri-county area, or maybe we're seeing, increase in overdose deaths, or even just overdoses in general, like in sisters. Then we can do a targeted messaging to sisters, and we can get information out in a real time way, versus kind of what Janice was saying, that a lot of the state data, we're a year behind. So it's what I like to say is it's not pretty data, that it's really kind of that data coming in, and we need to look at that and determine what do we need to do in that instance. And that's where this coordination and working with communications, getting alerts out, those kind of things are going to be really important.
But then like what Janice was saying, it's the tip of the iceberg, that if 68% of them aren't even, they're using the,
So we know that 68% because they're the people we're seeing through harm reduction and homeless outreach. And so part of where that 68% comes from are the people that have built relationships of trust with our harm reduction folks and are reporting the use of naloxone to prevent overdose. So part of how we get to that community and part of how we have that data is because we are reaching people that are not calling the police, not calling EMS, and not going to the ED. We're reaching them through those harm reduction efforts, homeless outreach, the stabilization center, the reproductive health center, the STD clinic. They're coming to us in many different ways that don't necessarily present to just hospital data, which has often been the source of data in our community. So this effort.
Yeah.
Go
so
ahead.
you're gonna pull in
Well,
those numbers too?
Yes,
into yours?
and thank you, that's what I missed, is it's also bringing all of those partners into
Right,
this,
that's what I
and
was
that
thinking, of going
coordination.
like, well, we've got 70% over there,
Exactly.
so.
Right.
And then also having them help get messages out, right? So it's that data in and that information that's supported out.
And this is why the primary measurable outcome for this particular role, this point 2 of the supervisor, is to get a clear, written, developed plan for how we respond quickly in real time in a coordinated way. We have a lot of resource right now because there's been some investment in, well, not in public health prevention, but definitely in harm reduction and substance use disorders, stabilization center. But we don't have, we haven't had the time yet as we've stood up these things to really coordinate those efforts. So that's the responsibility of this role in collaboration with those teams. Other questions about that before I move on? Okay. The next strategy is one you're all very familiar with. It is basically to continue to support what our stabilization center is doing. So one of the things we thought about when we looked at the resources is there's some resource up front that's more significant than the resource over time. We did not want to build a strategy that committed us to spending for a lot of additional FTE over multiple years when there isn't going to be an adequate resource to do that. Our stabilization center serves this population every day, is saving lives every day, is connecting people to substance use disorder treatment every day. Has connections to ideal options, to best care, to all of our key substance use disorder treatment partners that are good at working with the population that is not going to go to the ED, not going to call 911, but will come to us. And they are very much facing, still having to figure out how to support services. The Impacts grant is possibly not going to be funded again. It's looking likely that it may not be funded again in the next biennium, which means there's a significant gap. So we're proposing applying some of the upfront dollars to covering stabilization center services. The goal would be to divert individuals from the ED, as the stabilization center does, and or the criminal justice system, to prevent death by overdose or suicide and connect individuals with treatment, help them stabilize in their community and improve their quality of life. We're proposing $650,000 a year for the first 2 years and $150,000 or less in subsequent years, depending on costs of the other 2 strategies. No new FTE. This supports continued stabilization center services. Next slide.
So what's the capacity of ideal options? How many people can they turn?
I don't know that off the top of my head. I could find out for you.
I mean, I just wonder because, they do have capacity if there's somebody that wants to go and get help.
They do. I mean, we
They
refer
take
people to them
people-
all the time. Yeah,
So
we
they
refer-
take people, they never turn you away and say, no, we can't.
I can't answer that yet. I have to ask, but I don't hear a complaint that people are getting turned away from outpatient SUD services.
It's outpatient though.
Yeah,
It's not,
it is outpatient. They do
They do MAT.
They do MAT and they do detox outpatient. It's a different model, like where you can, with medication, help people detox without being in a detox facility for certain substances. So they have a pretty robust practice. They work really closely with us. They were
And
also
they're-
funded through the Burns.
Through the Burn Grant, and they are, they're really talented with this population. I mean, have lived experience. They have members of their team with lived experience that's pretty gnarly, and they can reach folks that are hard, even for our stabilization center to reach. So they're pretty effective. And they're just one. I mean, we have other partners as well. The activities of the Stabilization Center. As you know, the Stabilization Center provides a wide array of crisis services to the community, including crisis walk-in appointments, adult respite services, forensic diversion programs, peer support. ASAMs are an acronym for a substance use disorder assessment strategy or tool or protocol, and case management. Specific to substance use disorders, this includes walk-in SUD disorder assessment and case management, naloxone and fentanyl test strip distribution, referrals for SUD and mental health treatment, after hours and weekend behavioral health resource network drop-in services. So we are part of the 24-hour burn that was funded through Measure 110 funds. And the measurable outcomes for this particular strategy would be to develop an EPIC, that's our medical record workflow to document crisis substance abuse treatment related referrals, establish a crisis SUD referral baseline in 2025, and develop an improvement target for 2026. Questions about this particular strategy? Okay.
So we're like 23, so that's 2 years away. We can't do that any sooner?
Well, fiscal year 25 is when we can start establishing a baseline now. We just don't know, first of all, what the board will decide about the appropriation of these funds, right? This is a policy decision we're bringing to you. Then we hire people, and then we work on establishing the referral process in 2024 and the baseline. The baseline is really so that we can actually tell you whether or not we're making a change. So to have a baseline, we need a period of time. That does not mean, Commissioner, that we're not going to do the activities before 2025. 2025 is when we would have hoped to have done the activities for long enough to say, this is how many referrals on average we do. And then we would identify an improvement target. We would like to do more of those in the next year. And maybe we have a huge number of referrals that we make and good follow through, and we have a small improvement target, or maybe we learn that we really need to make some concerted efforts to improve on what we're doing. We will know once we begin to do this or collect data on it. It's not like we're not doing it now, but we would start to collect specific data on the number of referrals made.
There's a platform that we've been piloting at the Stabilization Center called Unitas that allows for tracking of referrals and getting more specific data around where we're sending people. Our current electronic health records does not really allow us to track specific referrals to different agencies. And so that's been the challenge. And so we're just going to build that existing system up and be able to track in more detail.
Yeah. So I thought it might be helpful to just talk a little bit about how this enhances existing efforts and how it relates to existing efforts so that you understand how it's part of an overall community-wide strategy. So our surveillance and coordination effort really helps keep connections with the Pain Standards Task Force and the Central Oregon Overdose Prevention and Response Entity. These are two entities that are already stood up, established, doing good work in the community. And the role of the coordinator or the role of the supervisor, the 0.2 FTE, would be dedicated to keeping connections. You can go ahead and click the next two. Keeping connections with those two entities and their work as we described earlier, as well as other entities. But these are two successful efforts that are occurring right now. In terms of the expert overdose prevention services, they will be connected to our existing prevention and health promotion activities. And Jessica could certainly share more about that, but there are quite a few. Take Meds Seriously Oregon, Upshift, Shared Futures Coalition, Healthy Schools, and the Central Oregon Health Council's RIP work group focused on behavioral health access and coordination, as well as actually substance use disorders. This role would work closely with our internal data for action team and our epidemiologists that work closely with Cooper and the surveillance that they're doing, and would work closely with our emergency preparedness coordinator in terms of managing and supporting health alerts. And do you want to talk just very quickly about which each of those entities does?
I can. So entity-wise, that's us. Your prevention and health promotion section is housed within Deschutes County, and Take Med Seriously Oregon is a website and campaign that we adopted with permission from Colorado several years ago, and worked in concert with the Pain Standards Task Force to really push out safe storage, safe use of prescription drugs. And that's an opportunity to also promote prescription drug drop boxes and those types of events. Our Upshift program is our alternatives to out of school suspension that is operating in some fashion in every school district in Deschutes County. That is a really critical work in that it allows a student who is either referred or was caught in violation of the school's policy, drug policy specifically, to be screened to either have some type of intervention, or if their level of use is such that they're in need of treatment, that we've developed a pathway that schools can take to get that kiddo to treatment. So it's pretty instrumental in the grand scheme of the work that we're doing here.
Do we know how many kids have gone in for drug treatment then?
That, I don't have that number off the top of my head.
I mean,
but
is it-
find out.
Is it pretty successful? I mean, if someone is identified as they're at the school and they have a drug problem, can their parents and them be communicated with in order to get them to help?
Yes.
I mean, is it like every time?
So I would say yes, however, the nuances are that not every family is supportive of their child going to treatment. So those are the barriers that might come into play. But overall.
But their parents would be a part of the conversation though?
Mhm.
They don't just leave the parents, okay.
Correct, yes.
Okay,
Yeah.
good.
And the other thing to remember is that in order to be eligible for substance use disorder treatment, you have to be diagnosed with a substance use disorder. So there's a lot of young people, however we feel about it, who may get caught with a substance but don't meet the criteria for addiction. So they might not even be eligible for treatment. It may be a kiddo who is doing okay, got caught with marijuana. We don't love that, but they might not meet criteria to actually go into treatment. So this is targeting kids who are being identified through this model. It doesn't necessarily mean that every kid needs drug treatment. It may mean that they need a conversation. It may mean that they need to talk with their parents about what they're doing or with their school, but they may not even be eligible for treatment.
Yeah, so whereas before in our school setting, a student would be sent home, suspended, and there was no discussion about that. It was just, figure it out at home. And so now we have this intervention piece where the student gets to stay in school, have a constructive 3-session, I believe, course, and the parents can be a part of that to the extent that they would like to be.
Other questions about these efforts? So this just gives you a sense of all the different things that are happening that this targeted opioid intervention and prevention activity would be connected with, added with, and coordinated with. Next slide. And then the last strategy, our Deschutes County Stabilization Center literally has links to probably everything. Touches so many different lives. You can go ahead and click through, Cheryl. Obviously, we're a certified community behavioral health clinic, which means we offer comprehensive mental health and substance use outpatient care. We're integrated with primary care. We have access to medically assisted treatment for any individual who needs it. We can make a referral for that, and we refer to substance use detox and treatment all the time. Our harm reduction program provides naloxone distribution, education, and training. It does specific outreach to vulnerable populations. It does hepatitis C specific testing and outreach, and syringe exchange. And then our homeless outreach services really has a connection to individuals who are struggling with addiction and mental illness throughout our community, and does intensive community-based engagement, assessment, and referrals. And all of those folks often end up being served also in our stabilization center. And I'll let Cheryl talk a little bit about the budget picture.
Sure. So there you have the fiscal years along the x-axis, and then in thousands on the y-axis. And so the way that the funding is being distributed is a little bit all over the place. Year 1 and 2, we've already received some distribution payments. And then there's one distribution that's at least a one-time expense that or payout that I anticipate we would get next fiscal year. In terms of one of the distributions, we're receiving up through year 5 in this particular fiscal year. So that's where you see the large amount that we already have, and we don't anticipate any expenses, or in our proposal, any expenses this fiscal year. It would all start in fiscal year 24. And then based on the strategies that Janice outlined today, would be expended through the course of the next over 17 years. So it would be a total of about 6.7 million we anticipate, and that could fluctuate. I know at least one of the settlements range from 57,000 to 82,000 a year. So this is estimated conservatively based on what we know of the payments. Also in the proposal is to cover indirects, which are allowed at a reasonable amount. So in this proposal, we've recommended it cover 28%, which is about the estimate internally, both from the county internal service fees as well as what we distribute for health services specifically. Questions on the funding?
Oh, this is the good stuff.
Did you build in projected increase in costs over the duration?
Yep. So with that, we've assumed, like with COLA, next year would be a 4%, then a 3%, then 2% ongoing.
So my thought is, this is a way that these settlement dollars could be spent, and I'd like to look for an opportunity to have other folks come to the table. I don't know if you got that feedback from me before or not, but sheriffs or public safety efforts, DA's office, drug court, maybe there's other ways some of these dollars could be spent too. And I'd like to maybe see us do that at coordinating, public safety coordinating meeting or something. Just are there other ideas out there for these dollars, these one-time dollars? Getting people lined up the best we can, knowing that this is serious business. I absolutely support sounding the alarm, just like you're saying. I mean, this is serious business that's happening right now. Also, there's places for action here. How do we either stop the flow, get people up to speed on what this really means? The homeless, health does a lot of great outreach there, but there's some action that needs to happen, as in specific people we need some people not to be located at certain locations. We're talking about trying to do Huddle Road or the east side of Redmond movements. How can we empower this action to happen? And I'm not trying to, push too hard on any specific person's life, but we can't just keep standing here waiting, offering services, and if they're not coming, what else do we do? So bigger picture, I'm just sharing.
Yeah, and I definitely heard that request. I think we had some internal conversation about it and don't feel that we're like, we don't have the ability to propose. We can propose to you what we think we are able to make use of the resources
Oh, yeah.
for. I don't know that
Yeah.
we're the people that can bring you the larger community plan. I do think we're doing, I mean, obviously, I think we're doing a lot of work that's already specifically connected to the efforts that are outlined in Exhibit E. It's not a lot of resource at the end of the day. So, and some of it comes right up front. A lot of it comes in pretty small amounts over a period of many years. So these are things to just think about and under consideration.
Yeah, well, and as I say, I'm just looking, are there some impactful things that we can do right now as a community, as the greater service group, referring to public safety, with health, with anybody, you know, well, let's go right now and do something serious here. People are losing their lives if they don't have the information. That this will just stop you dead in your tracks. You know,
Yeah.
opioids, fentanyl.
I'd like to know what, okay, so I know that CCBHC, we've had them for a little, you know, that program for a long time. What is our referral rate success? You know, I know a lot of times you see somebody's they go through drug rehab 4 times, they go through it 11 times. Maybe at some point in time, it catches and, you know, and they can go on with their life. But what is our success there, where you say you're referring to the detox, but what are the numbers there? Like, I mean, is it actually working? And then when you say you get people syringe exchange, I was talking to somebody today and they just said, oh my gosh, what's happening in Oregon? We're enabling, people are coming here for the drugs. And it's further putting more pressure on our health department. Because like they're coming for the drugs, okay? We all know that. But what can you do? How can you like convince them that maybe that's not the way you want to spend the next 30 years of your life?
So you're asking 2 separate kinds of questions, but in terms of referral rates, we do track as a community, and I can get you that data, the successfulness of referrals to substance use treatment providers as a community. We don't track it as an agency, but we track it as one of our global health metrics. So we track referrals to substance use disorder providers, and then engagement, which is, did people show up for an appointment after a visit to the ED for a substance use disorder? We can certainly,
I mean, I would just praise the people that you help them on Saturday, they've OD'd, but we've caught them in time. And then is somebody seeing them like every day for a while till they can get things stabilized?
So one of the phenomenon in our culture is that we value freedom of choice. And we have a very strong cultural commitment to not compelling people to do things against their will. And that means that we're not allowed to force people to get behavioral health treatment. Even if we can force them into the hospitals do not necessarily compel treatment, meaning they don't hold you down and medicate you until you become non-psychotic anymore. Substance use disorder treatment is the same. At the end of the day, people have to agree to engage, and even people who are incarcerated had to agree to be diverted. So at this point, we have a system that's built almost entirely on people being willing to engage in treatment. What we know is that a lot of people with addiction have to engage in detox or treatment multiple times before it sticks. That's a sad, we would all hope that with the first referral, there's success and people never use again, but we know that that's not true.
So what's the average number?
I don't know.
4.5 times,
I don't
and then
know.
they finally go, gosh, I've really been lucky today to like better change my ways.
Like, relapse on average, 4 times before we start to, I mean, that's old data though. I don't
Was
know
that
if that's
just,
accurate.
was it a real number?
Well, there is a number around
There is a
relapse.
number around relapse, but I don't know if it's different for opioid use disorder versus alcohol use disorder versus cannabis use disorder. I don't know that. There are probably people who know, and we could look for that information. I'm just thinking of I know the number of times people leave an abusive relationship before they leave for good. It's actually 7 on average.
Well,
7 times. So it's hard to stop doing self-destructive things and get yourself out of a bad situation. we know that people with addiction really struggle.
What about the program they're doing in Rhode Island? That's supposed to be really successful. Has anybody looked into that program here? Where they actually get him on a different drug, you know, and then seems to really actually work there?
That is what we're doing here. That's what MAT is.
Okay, but their numbers actually, I see their numbers and I haven't, do we have that same success rate here?
I
When
don't,
our overdoses have doubled, you know?
yeah, I don't know. I mean, a lot of why our overdoses are doubling right now probably has to do with the fentanyl crisis. That's at least what we hear from our internal experts. And I think there's no doubt that the COVID pandemic crisis contributed to isolation and increased rates. Sorry. It's allergies. I swear.
I'd like to jump in here if
Yeah.
possible. I think I hear from all three commissioners a desire to invest these funds in approaches that work. And I would just like to ask, I'm open to, I'm certainly open to other ideas and other proposals as well. But as we evaluate the concepts that have been put before us today, as we look at other ideas, I would like us to look at all of those options with an evidence-based approach lens. So it's quite possible, you know, Janice and the team have laid out a number of strategies for us today. Maybe we have not heard enough about maybe we have not heard enough of the evidence for these approaches and the success of these approaches in other places or here yet. But also, if we're going to entertain other ideas for the investment of these funds, I would like us to ask anyone who's bringing other ideas forward to also provide us with the evidence, explain the mechanics of why this proposal, this idea, this strategy works and has been effective either here or in other places. As we are talking about kind of the next stage of this discussion, I just would like us to come to it with that perspective. We want to invest in things that evidence demonstrates is effective, because a whole lot of people are going to have a whole lot of ideas about how to combat substance use disorders and overdose deaths in our community, but only some of those people are going to be able to bring a very evidence-based argument for why their idea is actually going to make a difference.
So as I mentioned, I think Public Safety Coordinating Council may be a place to have a great discussion. That could be the sheriff and the district attorney at the table, plus youth and parole and probation and all kinds of folks. And it isn't, I'm talking public safety, I'm not talking to police per se, but it just happens to be a table that I think that we could get the rest of some folks that could put interventions in place, maybe not the same ones the health department would, but let's see what we can do here. So I would suggest, and I have reached out to the sheriff and the DA just to say, there's a discussion here, some one-time dollars from many years. I support, the health department doing good things in this area. So we'll see where it goes.
Yeah. Well, we have a Public Safety Coordinating Council meeting tomorrow afternoon, and I will make sure to circle back with people that we had this presentation today, and maybe Janice and the team can provide a similar presentation to them.
Well, so, and maybe for the next, tomorrow's too short now we have substantive, but yeah, definitely get the word out. And this was my idea. If there's support for it, then, we're setting direction to it for the boards.
Right, I'm wondering, what is the death rate in Oregon for 22 then? Do you guys have that number?
What is the what?
Death rate per 100,000 in Oregon for drug overdose. It wasn't available on the National Center for Statistics. I'm just wondering, I
I'm
was charting the, it's going up like this.
I don't think it's come out yet. We only have the preliminary local data that's generated by.
The 28
Just put a
deaths.
lag in something.
Yeah, there's.
Do we know, we don't know the state number then? We surely, somebody has a state number, right?
No, there is not a confirmed state number yet.
Really?
It's always a year behind. They may be able to take guesses, but I don't think they ever publish that.
Yeah, I can ask her if.
And we were reluctant to even provide the
The
local
20.
data because we're not, it's initial preliminary data. And we always want it to be sort of curated before it's.
And we know there's a problem in the medical examiner's office in the state of Oregon, and that's incredibly important for all these type of things to happen. So I know it's like, I mean, I think that office is really short-staffed, and I would assume that that's part of the problem. Getting numbers. It will be, just to track this, it'll just be curious to see how bad it is.
So this one-time settlement dollars, is it already kind of routed through the health department, or what does it look like? Are we talking about next year's budget at this point in time?
Yeah, so the way we can distribute it to however makes sense, but right now it's all in the health department. We have 908,000 that we've received to
Sort of
date.
city that we haven't identified it, but that.
And you're getting interest on it, which is good.
Yes.
$1 million almost.
Can I,
Upside.
Yeah.
You should.
as we're,
Looking for the next partner, the next optimal partnership, or at least full on, sounding the alarm and doing the best we can across the whole organization. So Commissioner Chang, it sounds like you're supportive of sharing that tomorrow.
yeah, I wanted to describe or mention one other potential source of consultation or inspiration for us. We are one county among thousands in the United States, and I'm pretty sure that NACO, the National Association of County Organizations, has work groups and analysis and policy papers on the opioid crisis and effective opioid prevention and treatment strategies. It might be worthwhile for us to kind of check on what NACO has put out on these things, and it may very well kind of reconfirm some of the ideas that we've heard today or add to those.
So one of the things that I would just add is that a lot of what we're already doing now, both in health services, in the community through the burn grants, is evidence-based strategy. Those are evidence-based strategies. So I don't want to forget that piece. Like, there's a lot of work being done that's already based on the literature, on research, on best practices. And I think what we're proposing is just a way to better harness that and make better use of it. There may be a more optimal plan. But as we're thinking about evidence-based strategies, I think it's important to remember what we are doing currently and not lose sight of that. The Pain Standards Task Force has been very effective. I know that harm reduction is controversial, but it is saving lives so that people can have an opportunity to engage in treatment. And we certainly know what our internal rates of referrals are at the stabilization center. So we know how many people we see, we know how many of those people get an assessment. And we know that we've been effective at connecting those individuals to treatment.
And we know how many people report, they would have ended their life had it not been open and available. And a lot of those people do have co-occurring disorders and are struggling with substance use disorders. So,
but if there is more evidence or information you want, please let us know. We can bring that back to us.
So I remember when I was a kid in cough medicine, my mom said something about, does this thing have codeine in it or not? And I just remember the terminology. She was a nurse.
Mm-hmm.
But then I remember her talking about how, codeine in cough medicine was abused, and it was abused in Korea, in the military, and then Vietnam and everything too. People would just be looking for it. And then morphine and heroin, and now heroin's on the street in big bundles because people are taking a pill instead of having to worry about injecting heroin, and I mean, there's gonna be just like a dump on the street of this stuff. This is really scary time. And then fentanyl, I just looked it up online, you know, just thought, maybe I was looking at how to spell it or something, just to make sure I had it right. But you know, it was a pain control patch that you know, like amplified it in slow dose or whatever, and then now it's been weaponized and recreationalized or whatever. So, you know, it just puts it in perspective that, I mean, this is a multi-generational, you know, man-made painkiller situation, but it's just being ramped up and up and up. Scary times.
I know when they're pulling over drug people in, you know, we're on the drug corridor on Highway 97, and it, you know, they've got 36 pounds of this and 2 pounds of that.
Well, and why do they have 36 pounds? Because nobody's
Yeah.
buying it, because they're looking for fentanyl now, and a pill for them, but they can swallow it, so they don't have to do anything else. This is bad.
Jessica?
I just wanted to mention that these dollars are guided by a list of, I guess, what I would say are approved strategies for use. I've been calling it Exhibit E for lack of, I don't know what else to call it. So Exhibit E, yes. And we did take a look at that and really look at what are the gaps in our community. So just don't forget that Exhibit E is a list of evidence-based approaches, and to keep that in consideration.
Yeah, it already comes with sideboards and expected uses for sure. And there's a lot of opportunity in here for making investments in different areas too. So as I said, I just want to take
There are.
a higher level look at it with a few more people on the table.
Heather, thank you so much
Yeah,
for
thank you.
coming back to the team.
Thank you.
Okay, great discussion. Thank you.
Next steps, and we'll talk to the Public Safety Coordinating Committee, and then at some point come back to the board, to talk about what might be a process on evaluating what's been proposed by health and other providers within the Exhibit E.
And
Is
if
that-
it's helpful for us to present as lipstick, you know, that we could.
Yeah, as I say, not for tomorrow.
No, not
Yeah, I mean, let's try to set the table a little bit. Does anybody go?
I go.
Yeah.
It's not-
So yeah, maybe just set the table.
We keep asking for Holly to be added.
But anybody could be in the room, but yeah. I suppose.
Okay.
Okay, well, let's.
Well, just don't forget what Jessica said, the kids need to be educated sooner rather than later. I mean, surely we have the funding to do something to get out there for kids and parents.
Thank you.
Thank you.
Thanks, guys.
Okay, other items. Something I signed a letter, Mayor Ben was just asking if there was support for a letter saying, asking the Joint Ways and Means Committee to schedule up Central Oregon. And I said, sure, I'll put my name on there. So we'll see what happens with it. Michael Preeton is signed as the mayor and the chair of the Central Oregon Cities organization too. So yeah, just something I was able to support.
So this is something you supported as an individual commissioner?
Individually, yeah.
And today at 5:30, I am testifying on House Bill 3052. That's about the elk deer damage compensation funding. So I chatted with all my neighbors, and yes, the elk went in and ate $5,000 worth of hay in the blink of an eye. So, yeah. And the fences, they're pulling together those numbers. So it'll be interesting to see, but then people are thinking that they may have already left our community. Have they left Sun River yet? The elk.
I don't know, I just see him once in a while.
Oh, I see them constantly, but anyway, okay.
Anything else, Commissioner Chang?
I'll just share that I'm here in Salem talking with people about the drought package today, and also about that House Bill 3126, the bill to create these child psychiatric emergency service centers around the state.
Great, thank you. Anything else? We do have executive session today. We'll switch modes here. This will be an executive session.